Hello and welcome to Paincast, Conversations on Pain and Physiotherapy. This podcast is brought to you by the Pain Science Division of the Canadian Physiotherapy Association. I'm Tiffany, the host of Paincast and an executive member of the Pain Science Division. I'm a physiotherapist in Toronto. Bas has been a physiotherapist for over 40 years. Bas has an incredible, unstoppable passion for physiotherapy, and he continues to evolve even after 40 years, staying up to date with the current evidence and fine-tuning his practice. This episode is one where you'd sit back and soak in the experience and wisdom that someone has accumulated over many years. In part 2 of our chat, we discussed a shift in our thinking about the role of our hands as physiotherapists as research evolves, how we can address various patient expectations for physiotherapy, and advice for all physiotherapists who are listening. Before we start, as a reminder, Paincast brings together researchers, clinicians, students, and patients to facilitate discussions, knowledge translation, and critical thinking on topics about pain and physiotherapy. The views expressed in each episode are of individual guests, do not constitute medical advice, and do not represent the views of the Pain Science Division or the Canadian Physiotherapy Association. Enjoy the episode. Tell the audience a bit more how you use your hands.
The most interesting thing is when I do an exam. For instance, I do a simple straight leg raise. I go to the non-affected side. So now make your leg heavy in my hands, and I have a light, decent grip, and I start lifting the leg. And I talk to them about what it feels like to them, bring it up. Okay, now let's go to the other side. And as you grab that leg, it is the affected side. Immediately you feel tension. So this is my hands telling me that, and you start to move to say, no, to the patient. So do you feel the difference? It's, yeah, what's going on? So try to make it heavier. Let it rest in my hands. So now we go, oh, there it is again. You feel that? Okay, now let it go again. Use that as an education, what my hands are telling me, to tell them that notice your neuromotor protective mechanism, how strong it is. That's not you doing this. This is an automatic defense mechanism. So that's part of it. And then we explore things by supporting a movement. They feel safer. Having an open chain in a limb that hurts always creates much more alert in our alarm system than having a supported movement. So that's almost always how I use my hands. For a neck, the whiplash. Yeah, I can't turn my head. Yeah, no. Why not? Well, I can't go any further. Is it painful? No, but I can't go any further. Okay, that tells me it is a self-generated protective mechanism, non-conscious. So let's lie down. Let me hold your neck and your head, and I'll gently turn a little bit. I'll hold you, don't worry. They still feel the pillow. They feel my hands. And say, no, see how far you go now compared to when you were sitting? God. So a learning experience again. Where the forebrain learns that they're not going to die when they make their neck turn a little further.
Mm.
It's all about using my hands to help them discover things rather than making my hands change their tissues. I don't crack anymore. I used to have a real good reputation 30 years ago. Yeah, you got to go in there. Oh, yeah, you can crack your neck and your back. And yeah. I still get an occasional old patient say, remember you used to do my neck? I say, yeah, well, you're not going to ask me now because I won't do it. Say, well, I don't need it. But yeah, the specialization in adjusting joints and manipulating joints is, and I have some good friends who are in the orthopedic division, and the orthopedic division has integrated a lot more pain science in their approach and starting to move away from the minute details of joint alignment and identifying levels. Now, there is still value in manual therapy, but in my particular case, if I ever get a popping sound, it is when we do a sustained or an assisted stretch of the lower back or of the neck. And say, no, take a breath, now turn a little, oh, there's a pop, good for you, rather than, it's a more showy technique, and it is really hot stuff when it works. But no, it's not empowering.
Do you use manual therapy as a way of pain modulation?
Yeah, I hope it has that effect. Sometimes it doesn't. I use my hands as a bit of a guide, an assistant to allow them to explore things. I don't force directions. I just assist them. I ask them to move. And learning that they can make certain movements better than they thought they could is already a pain modulation, because now they can integrate more rotation in that whiplash on a regular basis, more chin tuck. The more and the more often you move, the more circulation, the more changes in pressure, the healthier your nerves are, and the less nociception you get. And that's the very global reasoning behind it. And if there is any ligamentous or muscular microscopic damage, it will also benefit from that, because movement is good for healing tissues. It can meld nicely together with hands-on. I don't do any forced range of motion. I help people stretch and find motor control in a stretched position, but it's not like I used to do where I force stretch on people's tissues. Mobilizations, I know people who sometimes mobilize a stiff shoulder. I've occasionally done that. Well, basically, posterior anterior glides, little inferior slides, little angular with the slides, movements with mobilization. Yeah, but it's all non-threatening. It's all very small part of therapy. I do that on occasion. Yep. The word stretch has brought it to mind that it's still to date in the occupational therapy assistant and physiotherapy assistant programs. The assistants are being taught to hold stretches for 30 seconds, and then sustained stretching is somehow better than non-sustained stretching. I hope they don't teach that anymore in the physiotherapy programs, because there's such elegant research showed that lengthening repeated 5 or 6 times has the same effect as a long sustained stretch. And I know how many people hate long sustained stretches that are not athletes. The non-athletes hate that. You have to stretch this. Yes, you're tight. You have to stretch this. I tell them you can lengthen tissues by just teaching your nervous system not to send so many signals to that muscle by saying, oh, I want a little more. I want a little more. Most people aren't shortened. They have a heightened output to a certain muscle. By sustained stretching, we talk about creep. Creep is necessary when tissue is actually contracted and you need the tissues to release. If you want to get a muscle to relax more and allow relaxation between the fibrils, it's a neurological thing. So if it's just pain and there's tightness in the hamstrings because there's knee pain, and the tightness in the hamstrings now contributing to the knee pain, do very short. Lengthen it, breathe out, then relax. Then lengthen it, breathe out, challenge that limit a little, relax. And people find sometimes gaining 20 degrees of movement within one routine rather than holding a stretch. But that's a bit of a pet peeve of mine. We're still seeing so much sustained stretching as essential.
I agree.
Thank you.
They're different purpose, different ways of stretching, right? If someone had a knee surgery and they had loss of knee range of motion passively, even, that's when I guess a long hold, low load stretch can be helpful too.
Yep. Yeah, if there's scarring around the capsule, things like that, absolutely. Absolutely. But that's usually self-generated much better than me with my hands. Figure out a way for them to do it at home. They can do it every single day, multiple times, which is much more effective than me doing it twice a week.
Yeah, absolutely.
For me, it's an interesting process because I realize how many aspects are always at play in my interaction with patients. To try and identify certain aspects or address a certain aspect, it doesn't address the physical environment of the office. I have in this clinic that I work at now, gorgeous office with a big skylight high above me and a big plant in the corner. It is warm, pleasant. That alone, same as my old clinic, it had a view of beautiful ravine with trees. The setting of your interaction space, that is an aspect that plays a role. So when I look at all of those, the colors you pick for your walls, the colors you pick for your furniture, so many aspects involved in physiotherapy. And this whole process made me think, holy hell, that is an awful lot of stuff that has gone on in my career, in my life, coming from where I was as basically a physiotherapy technician with great knowledge of pathology and physiology and all of that, but a technician looking for a diagnosis to slap something on that was supposed to help that diagnosis, to now being an interactive guide coach with patients. And I'm so happy to see what's happening in universities now where the patient story, patient-centered care, biopsychosocial components, and recognition of the influence of those aspects. That is very nice to see. I found it disappointing how long it took before universities started teaching a specific proper pain curriculum. I still hope that the alliance that sets the standards for the national exam will also grow with the science that we have.
Mm.
Not sure that the national exam truly addresses the practice of physiotherapy and the skills required there.
It's really difficult. This is not something you can ask on paper, multiple choice.
No, safety is, of course, always a main focus in the national exam. Are you safe with patients? But I speak to 35 practitioners twice a week on average. There is too much of reliance still to date on ultrasound, interferential, laser, shockwave therapy. They all may have some effect, but in the grand scheme of things, it is minimal to none compared to the patient moving better and learning how to do that. That to me is still a little bit of a disappointment that still exists today. Now, that could be a business decision by the owners of the clinic. I totally appreciate that. Because it can be downloaded to assistants and it frees up the therapist for assessments and for more meaningful manual things. But at the same time, it is sad that it still exists because it gives the population the wrong idea of what physiotherapy, in my eyes, should be.
Yeah, this is been thinking a lot about this lately. Where's the balance between managing or meeting patient expectations and also business expectations?
Yep.
Because those tools, patients are feeling like, oh, I'm getting something worth of my money. I'm receiving shockwave or whatever modalities I can't do at home. In a business perspective,
Yep.
this is something that patients will come back for, and this is something we will offer, and this is something that's sustainable in a way, right?
Yeah, and you're right. Healthcare and business do overlap. But I do think the clinic that I work at, 3 other physiotherapists that work there, all have this similar approach to mine. And they're much younger than I am. But the clinic is thriving.
Mm.
And it's not 3 times a week. So it is possible to do it. The problem is it takes time to build that type of reputation.
Mm-hmm.
And many times you come out of school with debt from studying, God knows what else. You don't have 7 or 8 years to sustain a clinic financially and grow the patient load that will actually make you successful in a practice. So you have to come up with something that is ethical and at the same time smart business-wise. I couldn't start a clinic this day and age. In 1986, when I worked with Doug Freer in his clinic, this was the only clinic in town, one physiotherapy clinic in Barrie. That was it. And then another one opened, and boy, there was a vicious competition. Now, well, the Barrie has grown about 5 times as large, but there's about, I'd say, close to 32 clinics. The competition is worse than ever. And I don't have good advice to anybody other than seek like-minded therapists and see if you can join like-minded therapists who may have already been in operation for 10 or 12 years and grow in there where people practice in a way that you can connect to. And please, all the things that I've said work for me. This is me growing as a physiotherapist. Everybody does it differently. Everybody has different approaches to their patients. And as long as it is ethical and fits with science, find people that you can connect with. That's the key part. It doesn't have to be a mentor, but just somebody you can connect to, their style, how they approach patients. And then you can probably build something that you can take out eventually when you start your own business. Non-competitive clauses are not effective because you cannot force patients not to follow you. Just want to throw that out there.
Yeah. Well, back to the expectation part of it. Do you ever ask what do patients expect from physiotherapy?
Yep.
What's the response that you typically get?
I'm thinking back at the last couple of weeks. The most common was, I don't know what's wrong with me. So I want to figure out what's going on. So a question about their pain, why they have it. And the result that they want is a strategy, how to deal with it. There are some others who said, oh, I'm in such pain. I want to get rid of this pain. This is interfering with my life too much. I want to get rid of my pain. That's their expectation. So it usually revolves around either quality of life or the symptoms, getting rid of the symptoms.
Actually, let's backtrack a little bit. Why do you ask this question?
I want to make sure that I'm not going parallel to what they have in their mind as a path. I want to be on the same path with them. And maybe we steer once we're on there, but I want to be on the same path with them. That I understand what they are expecting so I can address it in my way or readdress it or re-steer it. It really is important that I know what they are expecting. If they don't have a chance or they don't think about it or consciously consider it and express, I might be starting with them down a path that just doesn't sit right with them. And we still are the person in an office. We are still the authorities. So most of the time they won't redirect us. And then we're already lost in our relationship.
Hmm. That's a really nice visual to give. You want to be on the same path rather than being parallel with them. So when they say, I want to get rid of my pain, do you acknowledge that? I mean, you acknowledge that is something that it's bothering them. How do you address this goal?
It depends a little bit on what they present. If it is something that they've had for a couple of days and it is not a huge dramatic background story, they misstepped and now their back is so locked up and so painful. I like you say, you always acknowledge the fact that they want to get rid of the pain. No, I can really understand that. I wouldn't want to be in your shoes right now. I have been, and it's no fun. Whatever. It depends a little bit on what patient I have, what person I had in front of me. So yeah, I can only imagine that. And so let's take a look and see what is involved with your pain. And then we can explore a little bit. And then we start to pick away. What are the aspects that create that sense of, I am disabled, I need to get rid of this, this is so bad. And that leads to the conversation about what can amplify that situation so much that you now feel in agony. What can lead to that? It is a starting point that you want to get rid of the pain. So in order to do that, we have to understand it a little bit. So can we talk about that? That type of back and forth with the patient. So I understand that. Wow, of course I would too. So let's look and see what's going on with the pain rather than saying, yes, I will help you. Most professionals don't want to listen to their pain story. They deem to the doctor, doesn't want to listen to all the details. The doctors don't have time. I don't blame the doctors. They just don't paid enough to sit and listen, paid to sit and prescribe. So, and that's a terribly simplistic approach, but with pain patients, that tend to be the role they play. So it is a common question, and I do think it is a good starting point, and hopefully you can pull the patient with you on that path to exploring the pain rather than talking about how to fix it right away.
So, in a sense, that question of asking about expectation is your entry point to some of the education that you're providing. Like if they say, "Oh, I want you to help me correct my posture, correct my biomechanics," and that's your entry point to discussing relevance.
That's a common one. Yeah, I know I have bad posture. I want to fix that. It at least means that they have a physical concept that they need to address, and that is my door into movement, not into posture, good or bad, but into movement. And this will kind of help them re-steer a little bit, like you're at a computer desk and every time you hit enter, do a little funky stuff with your neck rather than paying $1,700 for a chair that's 2 inches higher. So yes, it's a starting point. Expectations really guide us. Doesn't take us away from our goal. Our goal is to be the best possible person for that patient. But that patient doesn't come with pain that we have to fix. They come with a problem that they have expectations about. So, because not all people want to get rid of pain. I've had patients who come and say, oh, I know I have this, and I will always have it. But I'm losing this and this and this ability, and I don't know how to get it back. So I get those as well.
Yeah, same. There were times when I asked the expectation question and I don't get the reduce pain or eliminate pain. I want to be stronger. Okay, yeah, let's do it.
Yeah. And hopefully it is not, I want to be stronger because then I hurt less.
It is another important point to ask, like, why do they have those goals? What does it mean to them?
Yep.
What does having better posture mean
Yep.
to them? What does being stronger mean to them? Right?
Yeah. Yeah. And sometimes the question is it aesthetic? Is it for your job? Is it because there's a sport you want to get better at? Do you feel that you need to do more around the house? Do you have to transfer your partner more? Why are you looking at stronger? And sometimes you get back, oh, so I don't get hurt too easily. So, and then we have a nice opening again to talk about pain and weakness and strength.
You briefly mentioned you want to be the best person for the patient in front of you.
Mm-hmm.
What do you mean by that?
I want to be able to not be in the way of their narrative. I want to be there with all the things I have learned, not to be their hero, but to be there with the information, with the experience, with the knowledge and the empathy to figure out how to move forward within their particular context of expectations and complaints and whatever. That is my ultimate goal. That good. So leave my dress of my daughter totally in her car, compartmentalize that, not be impatient, and not be too charmed by the patient who says, yeah, I know so much about you. Patients have been referred to you and they give you a compliment. To really be like an open blank page when they come in. Even the ones that I've known before, trying to be a blank page that will pull any drawer open of experience or knowledge or science or communication skills or whatever that is necessary. And it sounds extremely wishy-washy and philosophical, but it's really what it boils down to. There's no magic. We are all compilations of our experiences and our genetics and things that we picked up along the way in this nervous system that makes us. And we are interacting with another nervous system in a meat suit. We have to be able to be the person to help them develop the self-management strategies that are required to deal with pain, to deal with loss of normal physical abilities, loss of normal neuromotor skills. That's our job. And I think our job is to be the coach, the guide from the first moment on. And that is mostly determined, what kind of coach, what kind of guide, and what kind of path, by the patient's complaints, their goals and expectations. Of course, within the framework of our ethics and our standards of practice. Those are always in the background as the framework. So to put it strangely, one of the things in our practice is some patients asked at the end of the session, there's been a few the last couple of months, can I get a hug, please? Lost husband, lost their health care, lost their job. And we managed to help them a little. And at the end of that session, after having been in tears of relief, they asked for a hug. So I opened the door of the office, of course. Then I get a hug. That is something that I find in our society, the physical contact of people between each other is in some ways growing and in other ways getting restricted and logically getting restricted. Let me put it first and foremost in our profession especially. But that's why our hands and our attention and our empathy and our time with patients is so valuable to the patient because we give them undivided attention, not interrupted by phones, not interrupted by anything. We give them physical attention. We have touch that is of significant importance for their movement, but also it is safe, it is gentle, it is not coercive. And all of those things lead a patient to be comfortable to ask for a hug. So I do think that all of those parts also play a role in making us such a good profession to help patients learn to move differently because we can engender that trust by what we do, the time we spend, and the attention we give to them. Manual therapy plays a huge role in that as well. The confidence that you can be safely touched in a therapeutic way. There's so much around touch. That's why I said it's a little odd to get a request for a hug, and immediately I have to switch gears and say, yeah, open the door first, get a hug. It is something that we need to be attentive to, that what we do with patients is deeply important at times, and sometimes more important than we actually realize, because we're just seeing a patient. They sometimes go through significant life changes in our sessions, and we don't always fully, and even at my old age, don't always fully appreciate how significant it can be for them.
Wow, that's very profound.
The whole question about how my practice has changed with the understanding of pain sciences, an example of that would be a whiplash-associated disorder, where initially I used to do manual therapy up to the gazoo with translations, little mobilizations, and sometimes even grade 5, and acupuncture and interferential. Nowadays, we basically, for whiplash-associated disorder, I only do gentle guided movements, exploring range of motions and finding the limits, and then simply exploring the limits and having the patient learn how they can play with their own limits and create a sense of confidence that there's nothing dangerous going on and gain their range of motion that way. So that is so different from the start. In the start, I was the one fixing a problem. Now I'm the one helping them learn how to fix the problem. And I see the problem different too. It's not like, oh, you have whiplash, I have to mobilize it. No, you have a strong self-protective mechanism going on. You have to reprogram that. You have to restore that neuromotor behavior that is non-threatening. It's not danger. So that is dramatically different. And I do much less and much less often. There are so many times when I do an assessment, and that's the only session people get. Now, for whiplash-associated disorder, I will have them come back in a week. If they're doing well, they're progressing well, then you know what to do. Bye-bye. So, yes, the business plan is not very good, but in the long run it is, because they will refer others. Because you don't have to exhaust your extended health plan to see him. So, totally different than 30 years ago, where automatically, oh, whiplash, yeah, I've got to book you for 6 weeks.
In your way of practicing, would you ever justify a visit more frequently than once a week?
I haven't so far in the last 2 years. It's been 2.5 years now that I've been practicing only one clinical day a week, and it hasn't been necessary. Even if a patient said, you know what, I like the K-tape on my knee, that somebody did that for me and it felt good, then I explain to them why I think it might work. And then I show them how to do it themselves. There was one person with a very unique problem, and the only option they had was high-dose ultrasound. Had him come in with a colleague. Yes, that's why. High-dose ultrasound over a neurological issue, the scar. Yeah. Talk about ultrasounds being overused. It's the only time I've ever used it. And he was booked twice a week for 5 weeks.
Okay.
Yeah.
Yeah. A couple episodes ago, I interviewed Dave Walton.
Ah, funny Dave.
Wonderful conversation.
Great guy. Yeah.
I read his book on musculoskeletal assessment, and one of the concepts that really impressed on me was the arm's length approach. Every therapist have to ask the question, will the patient get better without my intervention?
Mm-hmm.
If so, don't have them come more frequently than they need to. Don't instill iatrogenic disability. That's the word.
Yep, absolutely.
So in that model of being a guide and a coach, hardly anyone need to come in more than one time a week.
I agree. And that is, like I said, the colleagues I work with, exactly the same. Limited intervention, maximum coaching, especially in the first session, the key session of any rehab. And gyms are cool, and for some populations can be very useful. We have a couple of dumbbells that we use to show the patient, and then we show them how to do it with bottles, bags of potato, or with a shopping bag filled with kilos of sugar. The key part is the first session where they get hooked into, hey, I can help myself fix this. And again, the clinic has been around for a long time, so it's also a self-selecting population that expects to learn what they have to do for themselves. But Dave was absolutely correct. Is there enough regression to the mean with these type of conditions that we can expect the patient to do the right thing and they will get better anyway with what we taught them?
Mm-hmm. What are some things you found challenging as a physio, either previously, not currently, or you still find challenging?
To stay honestly humble is at times challenging. Generally, I think I've been humbled by life enough, but there are some times when people are so thrilled that they've come away with a positive outcome that they give you the impression that you are really, really special. And I am positive from the people I've spoken to and I've encountered over the years that somebody 6 months out of university can do exactly the same as I do. Maybe not with the same communication skill across all age groups or whatever, but they can do exactly the same as I do. It just took me 40 years to get there. Others can do it much shorter. So sometimes I have to be careful that it was a great day. Don't get cocky. You were just there at the right time. And that's the hard part. It gives me great satisfaction. Somebody's happy, but I have to be careful that it doesn't go to my head because it's easy. Somebody thinks that you're the last thing since the newest thing since sliced bread. It's simple to gloat in that.
But regardless, you're still constantly learning.
Yep.
I mean, you have to. Is being humble sort of a necessary condition for that desire to learn?
That's a very good question. No, I think curiosity is sufficient.
Mm.
I think curiosity, desire to learn, maybe humility is not the word for that. I think it is more the uncertainty, accepting the uncertainty that this particular couple of pounds of gray matter cannot contain everything there is to know yet. Accepting the fact that when I grew up, we still had rotary phones, and I had to call an operator to talk to my sister in Canada when I was in the Netherlands in order to make a connection. So going through decades and decades and decades, now I can honestly say the world will forever continue to change and nothing stays the same. So that makes me want to stay on top of stuff within my profession. Politics as well, but it's all a different story. But yeah, I want to stay on top. And it's interesting. It's about people. And that's why we're in the profession, people. That's why I'm not doing, I'm not into animal physiotherapy because I'm people and I love animals. I could see myself doing that at some point because they're awesome too. But yeah, it is an interaction with a living human. Yeah.
What is your next item of learning or general direction you're heading towards?
And now I have to admit to something really horrible. I've never had specific targets in mind. One thing would lead to something else. Like David Butler quoted one article, and it was psychoneuroimmunology research that got me hooked onto that, which then got me hooked onto some anthropology of human neurology and the development throughout the eons. So there's no specific goal. I like to keep my eye on my feeds, my daily feeds from science discussion sites and from other areas. And that comes across, I get email updates about orthopedic research. I get email updates from psychological research. So, oh, yeah, that's a title. No, that's not that. Oh, that's a good one. Let me look at that. And then I get into the rabbit hole and disappear there for a while. And it's not guided.
Is there an area where you'd be like, I need to be better at this? Or, even today, having times where you are not as effective as you wish.
Mm-hmm.
What area is that?
In a non-patient setting, I note that I am not as careful in staying on my train of thought and not running all over the place. And I did that today in this as well, where it's like a squirrel with something shiny. Oh, that's neat. Oh, there's a peanut. Oh, there's so much that I want to address that I don't organize my communication well enough. I do that much better with patients because it's a very focused moment. Yeah, that's one thing I have to focus on much more. When I do a presentation, I did a presentation to some doctors and chiros and DOs in Vancouver. But that was also difficult because I only had half an hour to talk about certain things and show, and there were so many little things that could influence and could affect it. So tried to jam too much into too little, which kind of loses the cohesiveness of how I express my thoughts.
Interesting. On a personal note, I love listening to people like you just go on and on, picking your brain and just storing the treasures in my brain. As, I guess earlier career physiotherapists could be listening to this, and one of the struggles I've had, I struggle with the fact that I only have so little experience and know only so little, and for a fact that I could be better, a better physiotherapist. And that influence my confidence when I am seeing patients. But confidence is an important thing to help them perceive that you're an authoritative person who knows what you're talking about, so they don't have to come away judging and doubting your experience and knowledge. Any thoughts or advice on that?
It is difficult to step into your shoes because I already had 2 years in the army, 2 years at an international finance company, and 2 years in front of a high school class before I became a student and became a physio. So I graduated at 31 with a lot of other stuff behind me that influenced my level of confidence addressing people in a professional manner as a quote unquote authority. And I started out working in a psych hospital as the only physiotherapist in the whole building for 800 staff and 500 inpatients and 3,000 outpatients. So I'm thinking that not knowing everything or not being experienced can be used as a positive. It makes you eager to learn more, and you can express that with the patient as well. And patients, an old guy like me comes into you and says, "How long have you been practicing, Missy?" And you say, "Well, I'm in my, 4th month." "Oh, a real newbie." And say, "Yep, yeah," and very eager to learn as much as possible. So let's get started. Tell me about, the lack of knowledge and experience is not necessarily a detriment to your ability to think critically. That, to me, is something that I would highlight to patients. So, you know what? We've been exposed to so much information during my years at university. We've had to really become good at critically thinking about all those details, and that comes in handy when you do assessments with people with complicated problems. And sort of find way of making it not a detriment, but a motivator for you. Lack of confidence definitely plays a role. I had that when I started as a clinical expert at WSIB 5 years ago. There were guys that had done it for 8 years, and I'd heard them in my training. I heard them how they communicated with practitioners and had disagreement with practitioners in a very professional way. And the first time I was on that phone, I was well into my 60s, my late 60s, and I was nervous and unexperienced and lacked the skill. And I sometimes, with some practitioners that I spoke to, indicated that you have to forgive me. I've just started as a clinical expert, so give me a little bit more time. Or, after all, you are somebody with a master's degree. You are somebody who's passed all kinds of extremely difficult courses to get where you are. So inexperience, yes, maybe there's more that you can learn. There will always be more that you can learn, but you have a stink load of university behind you and in your head. So you know enough to know when you can assess something, when you can do some assessment. And in those moments, you're there because of so many freaking years of hard work. You don't get where you are by, just sailing through a course or two. It's not like you did a weekend course in dry needling. And yet Most people come out of there thinking they're experts. But you're an expert. Not with a lot of practical years, but you're still an expert.
How should young physiotherapists think about professional development?
That was a good question. Yeah. With the way science is developing about the specificity, I always love that word, of certain interventions and the prior plausibility that a lot of the interventions haven't been looked at with, I would not go into acupuncture. I would not go into osteopathy. I would not go into the orthopedic manual approaches unless you just want to do the extra level of hard studying about spinal segmentation and innervations. I would look into cognitive behavioral therapy and ACT, acceptance and commitment therapy. I would look into Peter O'Sullivan's work. And of course, the Lorimer Moseley stuff is right up there. Comes under quite a bit of criticism, especially by those who are involved in the research of neuroinflammation for pain and who see the nociceptive apparatus as our whole nervous system, including the brain. But I would look at those more rather than a specific specialization in a technique or a method, because they are lacking a plausible foundation. And there's quite a bit of research on the things that those methods are all lacking. And I would not waste time, effort, and money on that. I would look much more at those that are what we used to call the soft human sciences, that increases our ability to communicate with patients and to move forward and to obtain changes that are meaningful for them. CBT and ACT, absolutely. And some of the pain courses from Moseley and the NOI group, as well as from the Pain Sciences Division, anything from the Pain Sciences Division will be helpful in developing skills. You do not have to have specialization. You do not have to be AFCAMT, IFOM designation behind your name to be a good therapist. I never did the exams. I took all the courses, never did the exams, because by that time I already thought, why am I doing this? What is this going to bring me for my patients? It gives you a credential that doesn't mean anything to the patient in front of you. They have no idea what those letters stand for. CI, CAF, CI, whatever my acupuncture designation was. My member of the American Association of Orthopedic Medicine, they have no idea what it stands for. It doesn't mean anything. It doesn't enhance your effectiveness with patients. It does not. Same as kinesiotaping courses. My goodness. Be creative with a piece of stretchy tape. Save your money. So I hope I'm not alienating too many people who have a special interest in that. If I did, I'm sorry for your loss. But really, yeah, specialization, not very valuable.
Any advice you'd give to physios across different stages in their careers?
What do you see yourself in an ideal situation as a therapist? So what for you is the ideal situation being a physiotherapist? So what does that mean? And you can apply that to every stage anywhere in your career. What is the best place, time, location, type of practice? If you're not in it, you're here, and this is what you would think ideal, and that's what you have to work towards. The stages of practice, I've had no stages. It has been a continuous, non-stop growth, meandering left, right, up, down. It's like a slow-growing tree. And I think that at the end of a career, there's death. That's basically it for me. Or I'm mentally incompetent and they drag me out because I'm doing stupid things. That's possible. Human brain can start to falter. But until that happens, I will keep practicing. Keep in mind that at some point, you have to look after your retirement, so be smart with your money. Yeah, make sure that you invest wisely. Otherwise, stay curious, please, and examine your bias. Examine your assumptions. Really be critical, because you owe that to your patients. You owe that to yourself as a scientific professional. Be aware that our personal experiences mean nothing from a scientific perspective. The anecdotes. And people say that experience is one of the 3 points of practice, but it's a very small part. experience is a small part, as an evidence, very small part. So that takes care of the anecdotes. Be careful about your bias, because I had a hard time getting rid of that, and thank heavens to some people who dragged me out of that. But yeah, and I still have to be attentive to it.
Wow. That sounds like a good concluding thought, but any concluding thoughts before we hit the stop record button?
No, I really appreciate you taking so much time and asking a old Santa about his career. It's really weird looking back, and I can only say anybody who's seeing a podcast or listening to a podcast of the Pain Sciences Division is already on the right path, I think, to be a better therapist, because that particular division is doing what I think essential work in the development of physiotherapists across Canada. The information in the pain sciences is crucial to us being the best professional we can be in our community. There you go.
Thank you for your time, Bas.
My pleasure.
Really enjoyed the conversation.
Thanks.
Thank you for listening to part 2 of my chat with Bas. Paincast is a freely available resource for you to advance your knowledge about pain and physiotherapy. We continue to provide you with top-notch, evidence-based, and practically oriented content. To help more people know about this amazing resource, follow us, rate us, and share our content with your network. Follow us on Instagram at paincast.psd, where you'll find bite-sized knowledge in 1 to 2 minutes. You can also use the feedback form linked in the show notes to help us improve. Thank you again, and stay tuned for future episodes on pain and physiotherapy.